Well, thanks for inviting me. I'm excited to talk to you guys about some work that we're really passionate about. So ketamine use for treatment-resistant depression in adolescents. Just some housekeeping stuff. I don't have any relevant financial conflicts of interest to disclose. I've got research support from the following sources. So let's get underway. So adolescence is a critical developmental period. For those of you remembering back, it is the period of transition between childhood and adulthood. So it's sort of conservatively defined as 12 to 18 years in humans. And there's a unique set of behaviors that's conserved across mammalian species. So things like increased risk-taking, novelty seeking, and spending time with your peers. But adolescence can also be a really vulnerable time. It's a time of onset for things like substance use disorders or the emergence of some neuropsychiatric disorders. And so I think both the strengths and the vulnerabilities are both rooted in the idea that there is significant structural and functional change happening in the brain during this time. So I'm very interested in adolescent depression. Adolescent depression is a significant health problem. So it's been estimated that nearly 1 in 5 adolescents will experience major depressive disorder by the end of the adolescent period. In the US, suicide is now the second leading cause of death in this age group. The TADS trial showed us that 40% of adolescents with MDD will remain depressed despite getting initial treatment with an SSRI, so Prozac in that case. And then the Tordia trial after that showed us that of that SSRI-resistant population, nearly half will remain depressed, even if you change their medications and you add psychotherapy. And so that tells us, both the studies and those of us that work with this population, that we really need better treatment options and a bigger evidence base in this population. I share some suicide facts from the CDC. These are pre-pandemic numbers, but surveying high schoolers in the US, so between 9th and 12th grade, 17 had reported considering suicide in the last year. 14% had reported coming up with a plan. 8% reported having attempted suicide in some way, shape, or form, and 3% reporting that they had an attempt that required medical attention. The death rate is 13 per 100,000, which comes out to 5,500 per year. It helps me when I'm thinking about these numbers to have something to anchor it to. So this is a picture of Hamden High School. It's a pretty large high school that's just down the street from us in Yale. There are about 1,100 students. And so this death rate is the equivalent of losing about 5 Hamden high schools to suicide per year, which I think is totally unacceptable and is really a call to action for all of us to try to do something about this. So obviously we're at a ketamine conference, so we're going to talk about ketamine. So I'm going to go quickly through these slides because I know it's a sophisticated audience and you all have been talking about this quite a bit. So ketamine is a medication traditionally categorized as a dissociative anesthetic, a non-competitive NMDA receptor antagonist. It's used at higher doses in anesthesia, so up to like 4.5 milligrams per kilogram, pushed over a minute, versus the doses we've been talking about in psychiatry. So the best study being this 0.5 milligrams per kilogram infused slowly over 40 minutes. So ketamine rapidly improves depressive symptoms in adults. There's many studies that have shown this. This is one of the early ones coming out of Yale. So you can see that there's improvement in depression scores on the hour of hours compared to our traditional antidepressants, where the x-axis is, all the way down the wall, up to 8 weeks to improve symptoms. And this inset is just showing that the time course of depressive symptom relief is separate from that of side effects. So rapid depression improvement, certainly a desirable clinical feature. And then another, this is work from my colleague who just gave his talk, that ketamine is also anti-suicidal in adults, even after you control for its antidepressant effects. And I think that is a particularly important feature for us in child and adolescent psychiatry, where we live with the black box warning, which is still controversial to this day, but I think makes both prescribers and patients and their families nervous. This idea that something that's supposed to treat depression, which is a major risk factor for suicide, that it could, paradoxically have an increase in risk for suicidal thinking. And so ketamine is a compound that's both an antidepressant, but separately anti-suicidal, is very appealing. I'll say one summary slide about mechanism. Jerry did an amazing job yesterday with lots of very fancy cartoons. So this is just my mechanism for dummies slide, I guess. I'm just summarizing that prefrontal cortex and hippocampus are key sites of action. Some of the primary hypotheses are that NMDA antagonism on inhibitory interneurons facilitates glutamate signaling. And then a separate, but I don't think mutually exclusive hypothesis that ketamine metabolites may directly activate AMPA receptors. But just sort of summarizing that ketamine enhances glutamate signaling and promotes synaptic plasticity. So what do we know about ketamine and pediatric pharmacology? Well, we know that there's a lot going on in the brain at this time, particularly in areas that are important for depression, like prefrontal cortex. So there's synaptic pruning of glutamatergic synapses. Animal studies suggest that there's changing relative GABAergic interneuron profiles, and even changes in the receptor subunit compositions of important GABAergic and glutamatergic receptors. So there's a lot of stuff going on. We also take a moment of pause when we think about animal studies that suggest that the risk may be higher for neurotoxic effects of high doses, particularly in the developing brain. So I think these two things make us want to be careful as we're thinking about designing studies in this population. But on the other side of the ledger, preclinical data suggests that ketamine reverses depressive phenotypes in adolescent rats. And then probably more compelling, at least as we were starting this work, is that ketamine has been used safely as an acute anesthetic in pediatrics for quite a long time at this point, and is actually used pretty routinely in the pediatric emergency room. So at least in the acute sense, we feel pretty good about this being a safe treatment to design a study around. So we started a few years ago asking a very simple question. So is a single dose of ketamine safe and effective in adolescents with treatment-resistant depression? We called this the KIDS study. This was funded by the Child Study Center, the American Academy of Child and Adolescent Psychiatry, and the Thrasher Research Fund. And most of this data you can find in our paper that recently came out. So I will tell you about our study subjects. So we were looking for teenagers, so ages 13 to 17 in this study. We were looking for depressed teenagers, so they had to meet DSM-5 criteria for MDD. We wanted significantly depressed adolescents, so they needed to have a children's depression rating scale score of over 40. And we wanted treatment resistance. And so in this study, we defined treatment resistance as remaining depressed despite having at least one prior adequate antidepressant trial, which we defined as greater than 8 weeks at therapeutic dosing, including 4 weeks of stable dosing. As we'll see in a couple slides, the majority of our participants had failed multiple medications, and we had a pretty treatment-resistant sample. And then this was a ketamine in addition to kind of study. So we asked folks to stay on their medication regimen without any changes in agent or dose for the month prior to enrollment, and then during the 4-week trial itself. So who did we not include in this study? So this was an outpatient study. So we actually excluded folks that had suicidal ideation to the degree that it would require an inpatient stay. So an outpatient study, we excluded folks that had a history of psychotic disorder, manic episode, intellectual disability or autism spectrum. We excluded people that had a history of substance dependence, excluding tobacco or nicotine, or anyone that had a positive urine toxicology. We excluded pregnancy, and then anyone that was unable to provide written informed consent. A quick note about controls and blinding. So as you know, placebo rates are pretty high in depression trials, and they're really high in pediatric depression trials. And so we thought it was important to try to use a rigorous control here. So we used midazolam as an active control. And then we put additional measures in place to protect the blind, including having separate efficacy and safety raters. So the folks that were doing the efficacy ratings were at the Child Study Center. This is a nice nighttime picture of the Child Study Center. And then those were separate from the doctors that were doing the safety ratings at the infusion itself, which was done on the hospital research unit at Yale New Haven Hospital. This is the design of the study. It was a randomized midazolam controlled crossover trial. So it's a 4-week study. Infusion days were on day 0 and day 14. This is kind of a zoom in of the infusion day itself. So folks were randomized to get either ketamine at 0.5 milligrams per kilogram over 40 minutes, or midazolam at 0.045 milligrams per kilogram over 40 minutes. They received one compound on day 0 and the alternate compound on day 14. We used the CADS as our side effect rating scale, and then we also took blood work for PK studies in this sample. As you might imagine, we wanted to talk to these kids a lot, so we did rating scales on the days that you see here. And then in a subset, we did some neuroimaging studies as well. So the primary outcome for this short-term study was the MADRS at day 1. So this is taking you through our recruitment. So we assessed 26 participants, 19 consented for the trial. 17 of those 19 went on to receive the first infusion. So 1 withdrew due to an undisclosed medical condition, and 1 basically had a panic attack before we pushed the button for the first infusion and decided to withdraw. So of those that received the first infusion, the investigational drug service randomized 11 to the sequence of midazolam and then ketamine, and 6 to the sequence of ketamine and then midazolam. All of the participants on the left side completed the second infusion, and then 1 participant on the right side withdrew. She improved significantly after the first infusion and decided to go receive ketamine treatment in the community. This is showing some of the subject characteristics. So our sample was predominantly female, consistent with the gender difference in depression incidence that emerges at puberty. Our average age was about 15 and a half. But as you can see in the histogram here, we actually have pretty good representation across the age range that we were targeting. The average BMI was about 26. About half of them were local to Connecticut. You can see from the baseline depression rating scale scores, a 63 on the CDRS and a 33 on the MADRS, that these were pretty significantly depressed folks. The average age of onset for depression was 13 years, and the average duration of the current episode was 21 months. So quite a long sort of chronic course for a lot of these participants. The average number of failed antidepressant trials was 3.2, and this is only including SSRIs, SNRIs, or mirtazapine. Many of these participants had also tried things like antipsychotic augmentation or mood stabilizer treatment. This is just some more data on these participants, so showing that about half had a history of a suicide attempt, 60% with a history of non-suicidal self-injury. And then remember that the participants stayed on their current medication regimens, even though these were ineffective regimens to be in the trial. And so this is showing the medications that people were on during the ketamine treatment. So most people either on an SSRI or SNRI, about 30% receiving antipsychotic augmentation, 1 person on lithium, a couple of mood stabilizers, and then 2 folks that were not on any medication at the time. So this is the primary outcome from the study. So we were looking at day 1 MADRS. You can see here that ketamine decreases MADRS scores at 1 day following infusion. in this treatment-resistant adolescent population. The effect size here is 0.75, which is pretty similar to what you see in adult studies that are using midazolam as a control. This figure is showing percentage of responders. So we're using kind of the standard definition of response, which is having a greater than 50% decrease from baseline depression scores. So you can see in the green are 5 participants who had a significant response to both ketamine and midazolam, but then 8 people who responded to ketamine only versus 1 responding to midazolam only. That's sort of shown another way here in this box. And I've highlighted, I think, the most important comparison, which is the 8 responding to ketamine and not midazolam versus 1 responding to midazolam and not ketamine. We had 3 participants that did not have a response to either compound. This is the time course data, which was part of our secondary analysis. So this is showing the MADRS across 14 days. And you can see that on average, depression scores remained improved up to 14 days. So that was the last time point that we examined in this short-term study. So encouraging efficacy data, let's talk about side effects. How did people tolerate this treatment? So this is showing the CADS. So you can see this, I feel like the alternate title for this slide is that midazolam isn't the best control, right? So you can see that there's a significant difference in CADS score here, but I think the other take-home point to this slide is that these were transient effects that had dissipated by the second hour. And everyone in our group was able to tolerate these. So no one had to stop the infusion early or to use the emergent diazepam that we have on hand. This is just a list of the most prominent side effects that were reported on the CADS. So these are showing individual CADS items. I've highlighted ones that are similar in both the ketamine group and the midazolam group. So I feel like I have spaced out as something that's reported by participants in both groups. We also see I feel disconnected from my body, although, you know, that's certainly more prominent in the ketamine group. So again, I think thinking about, is midazolam an appropriate control? There are some similarities to the ketamine experience, but there are certainly some differences. One other area where there are differences are the hemodynamic changes that happen with these compounds. So this is showing in the top panel, systolic and diastolic blood pressure. Here, the asterisks are not showing differences between ketamine and midazolam, but rather are showing significant differences from baseline. So you can see that ketamine raises blood pressure and midazolam decreases blood pressure. On the bottom, you can see that ketamine increases heart rate and doesn't really do anything. Midazolam doesn't really do much with heart rate. I think the critical pieces of information are that, again, people tolerated the treatment very well. We had 4 participants who had blood pressures that met criteria for stage 2 hypertension in adolescents, which is a blood pressure of 140/90, but those pressures resolved. And then none, persisted at the end of the infusion, and nobody had an isolated blood pressure that exceeded 150/95. So no sort of hypertensive urgency or emergency kind of things happened. So I think the single dose conclusions are that ketamine was well tolerated in this population of adolescents, and that ketamine significantly improved depressive symptoms at 1 day post-infusion measured via MADRS in this population. And so I think this preliminary data, and I do consider this small study really preliminary data still, is that ketamine may be safe and effective in the short term, but like adults, it seems that a single dose really has an ephemeral effect. Some of these participants we followed kind of informally afterwards, and everyone ultimately did relapse. And so I think in some ways there's more questions than answers. So we have a lot of work to do, and I'll tell you a little bit about some of the directions that we're taking this work. So one is how to extend the duration of antidepressant action and to better understand maintenance requirements in this population. And then this one, which I think is just so important, maybe it should be like all capital letters, is the safety of repeated dosing in this neurodevelopmental context. Scientifically, I think ketamine also offers itself as a probe to potentially better understand the pathophysiology of adolescent MDD. So I want to talk for a couple of minutes just about considerations around repeated dosing. And what information we have about repeated dosing. And so some of the information we have about cumulative ketamine exposures come from studies of folks that are using ketamine recreationally. And from those studies, we see concerns about neurocognitive problems and also problems with bladder damage or this sort of chronic cystitis that you can see. So that's one sort of imperfect source of information. And another, I think, imperfect source are these animal studies. So animal studies, sometimes using high doses, but other times just doing chronic dosing of sub-anesthetic doses. And these show that in young or even adolescent animals, you can get damage to areas like prefrontal cortex and hippocampus. So things like neuronal cell death and white matter changes. So certainly things that we need to be paying attention to. And the toxicity threshold of repeat ketamine exposure is just not known. And so there's a lot of work that needs to be done in this area. So we have a couple of trials that are about to restart post-COVID or get started up in general. So I'll tell you about those. So the first one we call the SAD Kids trial, which is Severe Adolescent Depression Ketamine Intermediate Duration Study. So we took a long time to come up with this acronym. And this is funded by the Clinicians Foundation and ACAP. So that's one study that we ran a few participants through pre-COVID and are hopefully getting restarted very soon. And then I just received some funding for a new trial that I'm really excited about. We're calling it the READS trial for reducing adolescent suicidality, safety, efficacy, and connectome phenotypes of IV ketamine. And this is funded through the NIMH. Both trials have kind of a similar structure, which I'll show you. They both start with an acute phase that's sort of a standard parallel design clinical trial where folks are randomized to receive either a paradigm of repeat ketamine or repeat midazolam at the doses that I described in the single dose study. And then after this period of weeks, we break the blind and folks, you can see on the bottom, that received midazolam but did not improve are offered the open ketamine paradigm. And I like this because I think it kind of balances the rigor of having a parallel design double-blind study, but then I also think it's important that we offer active treatment to sick kids who are really struggling. And then in both of these trials, we follow all of the participants over a period of months using standard depression treatment and closely watching their mood, their cognitive function, and some safety measures. So the differences between these two studies, there are some subtle differences. So the first is the population. So at the top, we're sort of repeating the same type of population from the single dose study. So pediatric patients with treatment-resistant depression, here defined as having remained depressed despite having 2 antidepressant trials. In the SAD Kids study, our repeat ketamine paradigm is 6 infusions over 3 weeks. And then there's a limited number of symptom-triggered maintenance infusions. So 2 additional infusions can occur during the open period. A lot of folks say, well, how did you pick 2 over this period of 6 months? And that was actually at the insistence of the FDA, who's concerned about toxicity potential and sort of limited the number of treatments to 8 for adolescent populations in clinical trials, at least at the time that we secured our IND. The primary outcome for this study is a depression outcome, so the Children's Depression Rating Scale. And hopefully we'll be recruiting for that soon. And then the second study, the suicidality study, has a slightly different population. So folks have to meet criteria for treatment-resistant depression, but also need to have a recent suicide event. And so we're really focusing on suicidality in depression in this group. We sort of condensed the dosing paradigm here. So now it's 4 infusions over 2 weeks, and then we're following people for 4 months after that. And the primary outcome is a suicide outcome. So it's the ideation subscale of the Columbia. And so I think this kind of gets at some of the questions that I alluded to when we talked about the black box warning. We're interested in depression outcomes, but we're also interested in suicidality outcomes specifically. So hopefully the next time I talk with you all, we'll have some more information. So I would say I consider the current status of this field, cautious optimism, but I think the unknown risk profile of repeated exposures makes it really hard to feel super confident in our risk-benefit analyses because the risks are just not well defined. And so when folks don't fit within a clinical trial framework, I think patients should be truly treatment resistant. So I can't tell you how many times we've had kids that come in with these, labels in their chart, and then we go back and they've never tried, an 8-week course of Prozac and psychotherapy. And then we recommend that and they get better. And so I think it's important to make sure people have really tried the evidence-based treatments that we do have. Of course, informed consent about risks and benefits and the state of understanding in the field, and then direct supervision by physicians with adequate training, and then having a robust follow-up plan. I'm really excited about Sam's work with coupling CBT to try to extend the duration of wellness. I think a lot of the kids we've seen in our trial have been depressed for so long. It's really important to harness that period of wellness when they can reconnect with friend groups, get synced back up with their schoolwork and all of these things that, felt so insurmountable during the period of depression, and try to kind of regain some of that lost developmental time if possible. And then the last piece, as we have more and more pediatric patients and families that are seeking interventional psychiatric services, which I think of as not just ketamine, but also things like RTMS and ECT, we've heard a wide range of attitudes and practices that people have encountered. And no one has really kind of defined that landscape well, as I know. And so that's something that we're trying to do with a survey study. And actually, you all are the type of people that we're hoping to hear from, to try to understand what kind of cases you've seen in your practices, what's the availability of interventional services, the attitudes that people have, and the practice parameters. So it's an anonymous survey. You can win a $50 Amazon gift card. But I think more importantly, it would really help sort of understand the state of the field and help us focus our research efforts on the places where they're needed most. So I will stop there and say thank you to our patients and their families. This is a wonderful population to work with. Our current and past lab managers, the folks on the bottom, Michael Block and Jerry Sanacora, were mentors on the project that I presented. Kevin Kaloris is a pediatric anesthesiologist that helped us with the initial ketamine trial. Natalie is a medical student who is working on the survey project, so she would love for you to take a picture of that QR code and take the survey. She's leaving us for psychiatry residency in a few months, and is going to be an amazing psychiatrist. And then also our collaborator, Carlos Zarate, who helped us with the PK studies in the initial trial. So I'm really excited to talk with you all during the discussion section. I know there's going to be a lot to talk about, so I look forward to meeting you then.